for joining. I will go ahead and get started with our presentation today, which is about effective strategies to manage specialty prescription drug costs. Just a little bit of a welcome for me. I always like to say one of my pictures because it's 2 years and about 20 pounds heavier, but I did have a lot less gray hair back then. So hopefully the next time we'll all be together in person, you'll see me a little bit lighter. I have a lot more gray hair, but I appreciate everyone joining us today and getting together. Our agenda for today is to provide a welcome. We've got the Tierra CVS Health, who's going to talk to us about specialty RX strategies to make. Unmute, I think that would be a good idea because we hear you, because you're not automatically muted when you're coming into the conversation. And then we're going to talk about different resources about who Health Action Council is at the end and initiatives that we have going on. But in true Health Action Council fashion, what I'd like folks to do is we talk a little bit about, what is the 50% specialty drugs are really, on course to take about maybe 50% of, of all pharmacy drug spend. We talk about that, there used to be the 80-20 or the Pareto principle. I call it the specialty principle, which is 1 to 2% of your population is really going to be covering 40 to 60% of your drug spend costs. So it's getting a lot of people's attention. So, and this is really the question that we get here at Health Action Council all the time. My specialty drug costs are rising. What can I do about it? One of the hallmarks of what we like to do at Health Action Council is talk and share and get people to think. So we would encourage everybody to share your thoughts in the chat box. Rick Westfall will help me out and kind of comment on those. But the first thing that we'd like to talk a little bit about is, have you installed or adjusted specific specialty drug stop loss programs? So please use your chat box. Let us know if and what you're doing, what you've considered. I will, while the people are taking their responses, commentary on that, I will tell you that there has been a lot of activity around these programs. A few years back, ESI started a program, CVS is rolling out a program, Optum is rolling out a program. There's carve-out specialty vendors, specialty stop-loss vendors that are out there that have been playing in the space for for quite a while now. And I would also tell you that even amongst Health Action Council members, even the largest of large employers who've historically never really had stop-loss are starting to look at stop-loss. Strictly because these lightning strikes, these $1 or $2 or $3 million claims, especially for some of those newer drugs that are coming out, no one wants to show up in the finance department, with the weekly payment and say, hey, we've got another $1 million this week. So people are starting to look at specific stop loss programs for specialty drugs. Rick, I don't know if there's any comments out there for people to talk about, if anybody's had anything.
So Brian Lewis said that he and his organization are considering gene therapy stop loss for 2022. But that so far, Kevin, has been the only comment.
Yep, perfect. I think the gene therapy is certainly at the top of the list. The next question is, are you using manufacturer copay cards? I'd like to maybe take a quick poll on people who are yes, no's on that. I know there's some differing viewpoints on around high deductible health plans and integration with maximum out of pockets and the way these programs are running. So to maybe get a quick rundown on manufacturer copay cards, and copay cards are different from the patient assistance programs, and I won't take CVS's thunder on that, but I will kind of put that out there. Rick, I don't know if anybody is commenting on the copay cards and what they're doing.
Save RX through Express Scripts is our answer thus far. And again, everybody, you can answer these chats in the lower right-hand portion of the GoToMeeting control panel.
Perfect. And then the third thing is are you adjusting employee costs or changing your plan design, on specialty drugs? If there's anybody, looking at that or making adjustments to their specialty drug plan, we'd love to hear about that as well. And then lastly, as you're editing in or you're putting comments out there down in the chat box, You know, what else have you considered? I think one of the things that we like to do is say we don't have, you know, the patent on knowing everything about what's going on and what people are doing. But I think it's a great idea for people to share things that they've considered, where they're at on this, how much have you explored it, and, you know, is there any, you know, relative value, or have you had success or not? So if we can all help each other out a little bit, that's one of the core things that we like to do here at Health Action Council, is share ideas.
One of the ideas that came in, Kevin, is an organization is considering raising the copay for non-preferred plans, or excuse me, non-preferred brands, I should say. Copay forgiveness also for asthma and diabetic prescriptions if purchased through employer-sponsored clinics.
Yeah, nice. So those are good ideas. Yeah, and that'll tie in well a little bit later to some of our other conversations. One of the things that we've been studying here at Health Action Council is social determinants, and, you know, making available for individuals and providing them access to medications that will help keep them out of the emergency department or manage their lifestyle better, I think is always a great idea. So good. Anything else, Rick?
That is it, sir, so far.
Well, terrific.
Oh, excuse me. I do have one more. I apologize. Adopting preventive prescription drug lists, higher cost share on specialty. Just came in from Chris.
Excellent. Thank you. Very common. I think that's an excellent idea as well. With that, please be able to keep them coming in as we're going through. I will turn it over to Brian Rosenson from CVS, and he'll make an introduction of our guest speaker today.
Hi, everyone, and thanks for joining. It's our pleasure to be here. My name is Brian Rosenson, and I'm Vice President of Business Development with CVS Health, and it's my pleasure to introduce our speaker today, Tierra Ford, who is Senior Clinical Advisor for Specialty Client Solutions. So Dr. Ford's responsible for representing the specialty innovation, products, and programs to prospective and existing PBM clients. Dr. Ford's responsible for engaging and educating our internal employer sales and account team members on the growing specialty business trends and marketplace dynamics. She also consults with clients on specialty initiatives to help control costs. Prior to her current role, Dr. Ford served as a clinical advisor pharmacist with CVS Health. In this role, she provided strategic clinical pharmacy support to various national employers in the southeastern United States. Her responsibilities included consultation on pharmacy benefits and providing insights into drug trends. Dr. Ford has over 15 years experience in the pharmaceutical and pharmacy benefit management industries. She previously worked as an associate director of medical outcomes with Pfizer, where she was responsible for providing pharmacoeconomic modeling of various brand medications to assist with informed formulary decision-making for integrated health delivery systems. Dr. Ford received her Doctor of Pharmacy from Florida A&M University College of Pharmacy. She also completed a postgraduate pharmacy practice residency program with the University of Minnesota Fairview Hospitals and Clinics in Minneapolis, Minnesota. Dr. Ford is located out of her field office in Charlotte, North Carolina. And without further ado, I will hand it over to Dr. Ford.
Thank you, Brian, and thank you, Kevin, for the opportunity to join the discussion today. Very excited to spend a couple minutes talking about what we are finding to be the #1 concern and issue facing our mutual clients today, and that is really around specialty management, specialty utilization, and just seeing and hearing some of the responses that you all have shared as to, you know, what are you seeing, what are you hearing, and how are clients managing specialty today. I think it will fall right in line with some of the information that we're going to be sharing here over the next half hour or so, and encourage you to, you know, please interrupt me with any questions that you might have. If something resonates with you and you want to know more, definitely welcome that opportunity. So if we transition into the next slide, I think it kind of goes without saying that, as I mentioned, specialty is the #1, you know, concern for our mutual clients today. Kevin shared, you know, that we're seeing the cost of specialty, we're attributing about 50% of spend, and that's really what we're seeing in our book of business as well. This slide kind of describes for you, and I think we all know that it's about 2.5% of specialty utilizers that are driving 50% of the cost. And Why we're seeing this is because of, an aging population. We're also seeing a very robust and strong pipeline and specialty newer products coming to the market, expanding indications for existing specialty medications as well. And all of this is really driving to more and more people being started on specialty than we've seen in the past. But when you think about what it is and what can we do to manage that specialty, you really have to think about it in two different buckets and where that spend is really coming from. And that's what the right side of this slide is showing you. We're finding that about 11% of costs of specialty are really coming from those new utilizers and those that are new to therapy. So thinking about ways that you can influence and impact and make a difference in ensuring that it's the right drug at the right time for a patient in their specialty disease progression. And then the majority, though, of that spend is coming from those existing utilizers. So, what can we be doing there to make sure that the medications that members are started on are effective, that they're meeting the intended clinical outcomes? And if not, what can we do to address that? And so I know that as we move to the next slide, many clients are, really being faced and challenged with exactly that. How do we manage and address those two components? And just because of the amount of spend that you're seeing and the specialty space, it really challenges, plan sponsors and benefit departments and CFOs to really explore multiple options, even going outside of a traditional PBM relationship to, carving out aspects or components of specialty management. And I know that you guys are likely having those conversations or being approached by those questions as well. What you see on this particular slide is really to kind of level set what we're seeing and what the conversations that we're having around specialty carve out. And what we found is that there's various types that exist out there. And it's really important as clients start to evaluate their options that they understand exactly the differences of the different types and how it is different from the connected or integrated approach that they may have today through their PBM. One of the types that we are seeing is around utilization management carve out. So this is where a vendor may be responsible for creating as well as evaluating criteria, the prior authorization criteria, and developing that criteria to, lead to savings through denials. There are also types that look at copay optimization, where the goal there is to maximize the value that's available from the manufacturer copay cards to offset the plan sponsor's share of specialty claims. Another type that's common in the marketplace today is around condition specific. We're seeing more and more of these around fertility types of specific carve outs where they can be responsible for the formulary as well as the utilization management and the dispensing of medications for a particular disease therapy, such as fertility or hemophilia. We're also finding many foundational types of carve-outs where they are leveraging funds that were intended and set aside for charitable organizations to provide coverage for either the uninsured, underinsured, or indigent population to provide access to specialty medications through foundational dollars. However, some entities are taking those funds and applying those to offset plan costs for specialty medications. The bottom two are, the next one I should say, in international sourcing is another type of carve out that we're hearing a little bit more about today, where it's one of two things. It's either sourcing specialty medications from international offshore countries, or medical tourism, where the vendor may be paying for a member to fly to a country like the Grand Caymans or Mexico to be seen by a specialist, then treated and receive their medication, and then they fly back home. And the final is a full carve out, where it could be a combination of any of the ones that I just walked through, or in combination, or just a full carve out from dispensing, adjudication, utilization management, formulary, and the like. So, it's really important as clients are approached by multiple vendors or different vendors that are, stating that they can assess and help with the specialty savings, that they really understand exactly what it is that these entities do, and what potential benefits they may see, but also the potential risks and implications that may be a result if they were to carve out in any form from their current arrangement. Let's move to the next slide and talk a little bit on things that it's important that clients kind of consider on the next slide. So we know that in some of the feedback that we as an organization have received as being a PBM that owns a specialty pharmacy, there's a concept of the fox guarding the hen house, a lack of trust, a lack of transparency from the PBM relationship. It's really, in addition to the need to better manage specialty, is kind of leading to these types of conversations. And what we're seeing, many of the entities that are realizing that significant savings to clients, we're seeing, percentages anywhere from 30 to 50% in savings. And it's really important that when clients evaluate that they're looking at an apples to apples comparison. Oftentimes these can be reported as gross savings, whereas, any current solutions or programs that they have in place may be in net savings. So it's important to look at things side by side. There's also benefits that these entities promote, that they have tighter control and more rigor in their clinical criteria, leading to, higher denial rates. If you have higher denial rates, then you're going to have fewer people started on specialty medication. So you're going to have an impact in lowering utilization. They also mentioned that because they're not, associated with a PBM, that there's no incentive to dispense. There's no incentive to drive members to a specialty pharmacy or specialty medications, and therefore they don't have that conflict of interest. And then, there's also the thought around, chasing rebates, and, the PBMs and pharmaceutical companies, have some relationship that PBMs are chasing rebates, and therefore, by not having that arrangement, there's a little bit more transparency and or better savings that can be had. So those are just some of the benefits that we have looked at across the spectrum, if you will, of specialty carve-out types. But when looking at them relative to a current contract, current relationship, it is also important to look at the risks that may exist. So when they speak about savings, it is important, as I mentioned, to not only look at it from an apples to apples comparison, but also look at what potential financial impacts there could be if a client were to carve out. When I say that, I mean, could there be adjustments to any type of pricing guarantees, rebate adjustments? Are there additional administrative fees that the carve-out vendor may assess? All of these things, when taken into consideration, may start to erode the actual savings dollars that, or savings percentages that these entities may be advertising. So something to think about there. There's also safety concerns, and especially when you think about carving out to international offshore procurement of medications or offshore treatments. Because there can be a lack of coordination once the member is back here in the United States. Do they have a clinician that they're following up with? Does that prescriber have visibility to the medications that they're taking? Are they managing side effects? If there's a case of a drug recall, is it being tracked? Is there transparency? So there's potential safety concerns. There's also the fragmentation and confusion from a member experience. So, you know, where do I, if I'm carving out, where do I access my specialty medication versus, you know, something that I may be taking for diabetes or hypertension. There could be delays in access to medications, especially when using, you know, foundational support or some of the programs where the member has to qualify or meet certain qualifications in order to get coverage provided. And those delays can lead to potential exacerbations in their condition, potential, you know, emergency room visits or hospitalizations if there is that, you know, breakdown in access to care. And then finally, the administrative burden. There's, you know, oftentimes we're finding that some of the carve-outs do not necessarily have the framework and the infrastructure to really, you know, manage through integration and accumulate of ACUMEs and medical and pharmacy claims and the transparency and reporting that can be problematic and just something that plan sponsors need to be aware of as potential risks, and as they're assessing all of this, taking those into consideration. So I don't know if there was a question from the audience. I'm going to pause and ask if there are. I welcome them before we kind of transition into ways in which, you know, I do think that plan sponsors should be thinking about specialty management to address the key drivers. So I'll just ask if there are any questions at this time.
Tara, there's not a question. There was a comment. I'm just going to read to you to see if this is in context that just came in. If a person goes off plan to get a savings, is it true that the member deductible and the maximum out of pocket can be disjointed and not accumulate properly for patient?
That is true. That is accurate. And you know, that is one of the things that plans need to take into consideration, especially if they're using copay cards and other types of programs where you want to make sure that what the member is paying out of pocket is truly, you know, being counted towards those deductibles. They're not meeting them, you know, prematurely or earlier than they should, and that you're able to see that the accumulations both from the medical and the pharmacy, and that's not always as transparent and visible, which can lead to you know, additional complications and costs as well.
Thank you.
So if we move to the next slide, I think it's a transition, but then really getting into the way in which we have positioned how to think about specialty management. And if you go back or think back to that initial slide, looking at that 2.5%, driving 50% of the cost, you know, 11% of that is really those new to therapy, but the majority, 89%, is really once they're on therapy, how can we address? So if we move to the next slide, you'll see, first and foremost, it really is important to think about specialty management from a clinical appropriateness framework, and making sure that we want to ensure that members are started on the right drug from the very beginning, based off of clinical guidelines, based off of criteria that's developed by clinicians and that are experienced and experts in particular disease states, and ensuring that we do so, but we prevent any unnecessary utilization. We have, through our specialty guideline management or specialty prior authorization criteria, had several enhancements over the last 2 years, I would say, that have really taken this a step further to provide higher level of clinical oversight by adding, medical director review to specific high cost classes like hereditary angioedema, hypophosphatasia, shortening duration of approval rates. So, ensuring that members that are started on therapy, that they, within 12 months, 6 to 12 months, come back through a review to ensure that the medication is working and it still is appropriate in meeting those clinical outcomes. And then also leveraging electronic health record connectivity to make sure that we're getting to the source of truth to help inform those approval and denial decisions. And in doing so, that we reduce the administrative burden, the need to fax back and forth, call the doctor's office for PA submissions. And we're finding that we're seeing about a 2.3% increase in overall denial rates. Now, that's not to say we don't want members on appropriate medications. That's just to say that we have increased ability to be able to identify inappropriate utilization from a specialty standpoint. The other aspect and that happens early on is ensuring that we're providing those specialty medications at the lowest net cost through formulary strategies and having that work in concert with the prior authorization criteria, as well as any type, and making sure that we're providing, the lowest unit cost, net cost, but also working with plan design. So I think someone mentioned, that they're familiar with plans that are looking at, changing, copays for, non-preferred, specialty brands, or, but also taking into copay card types of arrangements with, like Prudent RX as an example through CVS Health, where you're providing not only a savings to the member, but also to the plan sponsor, again, to help address the lowest net cost available for specialty medications from the very beginning. So if we move to the next slide and kind of think through now, once they're on those specialty medications, what can we do to ensure that they remain to be appropriate and that we eliminate any potential wastage? First and foremost, you have point of sale, edits in place, refill too soon edits to make sure that, members are not refilling their medications too early and, stockpiling, or that we have quantity limits to make sure that there's no inappropriate dosing escalations. But I will say something that we have continued to invest and innovate in is how can we use and leverage our digital infrastructure to take it a step further to ensure that there's no additional waste. And if you think about specialty medications, even though a member may refill their medications 3, 4, 7 days early each month, over time they can accumulate up to a month's supply of medication. We have a way of using our digital framework to identify over a 365-day look back period. If we identify that a member has, based on how we've dispensed, how they should be taking that medication and that frequency, if there's a potential for them to have accumulated more medication than they needed on hand, we can automatically adjust or reset their next refill date to bring them back in line with an appropriate quantity. And you're seeing that first section on this slide is when we do that, we have seen about a $1,200 savings per specialty patient in just the first 10 weeks of us rolling this out. We also have added additional patient-specific weight-based dosing, indication dosing in the autoimmune category to start, recognizing that drugs like Humira, Stelara, Enbrel, They're indicated for many different autoimmune indications and have varying dosing ranges based on those indications. We want to prevent any unnecessary dosing escalations or patients to get higher doses than what's really recommended for their indication and their specific weight. And then through our embedded nurses, we have the ability to manage these patients, help them manage adverse side effects, keep them adherent to therapy through digital communication as well as telephonic, which will essentially lead to lower hospitalization rates or emergency room visits and the associated savings and improved outcomes clinically from that through our coordinate nurse management. And then finally, on the next slide, as we talk about eliminating waste, we also want to look at where are there opportunities to intervene when needed. So when a drug is no longer working as intended, or there's untoward side effects and a patient may need to change therapy, when can we potentially have a conversation with the provider to intervene to change therapy, stop therapy, or switch? And so this is something that we are continuously involved in and investigating to ensure that we can work alongside providers in that regard. We use digital real-time symptom trackers to identify those opportunities and again, engage providers when necessary. We're also exploring the options to look at new ways to either provide drug holidays or to use non-specialty medications earlier on in a specialty member's condition before they would actually need to progress to more expensive specialty therapies. So how do we bring this all together? Did I hear a question?
Yeah, we do have a couple questions actually. As I transition our screen back over to Kevin, if an individual is on an HDHP and getting meds at a discount and not accumulating towards the deductible, does it disqualify a person from contributing to their HSA?
Let me make sure I understand. If someone is on a high deductible health plan and, can you repeat the question? I'm sorry.
And it says, and getting meds at a discount and not accumulating towards the deductible, does it disqualify them from contributing to an HSA?
I wouldn't say disqualifies them. Sorry, this is Brian chiming in. It doesn't disqualify them, but it doesn't allow for medication therapy management, utilization management programs, and it wouldn't be seen by the system. So, if it's not accumulating towards the deductible because it's not adjudicating through the RX benefit, then that can cause some of the issues that Tierra focused on. Does that answer the question? Or did I interpret it right?
We'll see. We'll see if Brad responds to that. I do have a couple other questions that I can present to you too. How are you tracking excess drug accumulation, patient stockpiling? Are you tracking in real time? Is patient logging, or is the patient logging?
Yeah, that's a great question. So we're doing that through digital. We're reconciling that through our specialty pharmacy aspect and looking at what we're actually dispensing, what the members' frequency, how it's prescribed, and then we can determine based off of when they've received their refills versus how they should be taking the medication. If we identify that a 30-day supply, so a month's supply of that medication or more should be on hand, we will automatically reset and notify the member that their next fill of their specialty medication will be on this future date. If the member, has the ability to say, hey, actually, I don't have medication on hand. I do need that refill, or, my doctor changed how I'm, taking the medication, so I've been taking a little bit more, and so I'm actually out. We do have the ability to go ahead and fill. That would be an exception, if you will, and we have reporting that can track that. But I will tell you that what we have seen since we rolled this out is that, that we have a high percentage of members just taking that adjusted refill date that brings them back in line with the appropriate amount of drug on hand. I mean, our specialty pharmacists do still have that conversation, and they will say, hey, do you have enough drug on hand? Do you need a refill? And what we found is that members will say, yeah, I actually need my refill. They do refill a little earlier, just for safety's sake, or feeling as though they want to have that medication on hand. And so we have found that it's not unlikely for members to say that they need more medication than they actually do. So by automatically adjusting that refill date out, it does lead to savings. It brings them more in line with the appropriate quantity on hand, and we're not finding that in doing so, members are calling and asking to readjust. They do just accept that new date, and that does lead to savings.
Thank you, Tierra. I have one other question for you. I would like to address the audience. If you're not speaking right now, just to make sure that you're on mute. And furthermore, for those of you asking for copies of Tierra's slides, we will happily send copies of the slides out to you. Does CVS Health have a position on biosimilars, or what are your thoughts personally on biosimilars, Tierra?
Yes, I would say that we do, have some preferred biosimilars that are available, that are specifically on the market today. And our overarching goal is that we do want to, deliver lowest net cost, whether that's through generics, specialty generics, or biosimilars, as well as, preferred, arrangements that we have with brands. That being said, with specialty particularly, I think we're going to start to see more of biosimilars taking a more prominent place when we have more drugs that are on the pharmacy side available. So Humira, I believe, and Enbrel both should be expecting biosimilars by 2022, 2023. And as such, will drive more competition in that space from a cost standpoint. But then also, I think the other piece that will is very important is prescriber comfort and educatability with biosimilars as well. So I think to answer your question, it is something that we're continuously monitoring and looking to have preferred strategies where we can to offer that lowest cost for members.
Hi, Tierra. Thank
and
you.
We're likely to see
I do
more
notice
of that here as we have.
I do notice that you have 3 more slides. Do you want to cover the information on these last 3 slides, Tierra?
Sure. So let's go to the one slide, I believe, that talks about bringing it all together. And really, it is just a visual to provide a member journey and specialty. There you go. And really talk about each of the points that I highlighted on the previous slide. So we're going to use rheumatoid arthritis as an example, a patient newly diagnosed. But starting at the 9 o'clock position, it really talks about starting with certainty and ensuring the appropriateness of care from the very beginning. That's where the clinical criteria comes into place, and where we're seeing significant savings, 11.5% in savings through our managed criteria. Also, that interconnectivity with the electronic health record, being able to leverage the member's chart as the source of truth to help inform those approval and denials decisions, really leads to higher denial rates, where we're able to identify inappropriate utilization and get those members through that process sooner by reducing administrative burden. If you move to the, I would call it 1 o'clock position, as part of the onboarding process, we're making sure that we are going through the members' plan design and educating them on any copay card availability that exists, as well as giving them the opportunity to receive their medications for specialty through Prudent RX for those plans that are enrolled in Prudent RX at $0 member cost, but while at the same time providing plan sponsors the ability to maximize the value from copay cards from the manufacturer. At the 2 o'clock position, we talk about convenience of access. So again, as part of that onboarding process, regardless of whether or not a member chooses to have their medication filled and delivered to a retail pharmacy at CVS, or to have that medication shipped to their home or office, they have that convenience of choice. We're finding that, patients, 97% of them prefer having this option because it gives them the security of knowing that they're not going to have their expensive specialty medication sitting on a doorstep for hours if they're not at home, or if they happen to live in an apartment building, just knowing that it will be secure. They have that flexibility of go to their local CVS store and pick it up, where they may be receiving other medications as well. The bottom, moving to the bottom half of the slide, or about 4 o'clock position, we're also talking about that EHR connectivity and how we're leveraging, digital tools, secure text messaging to help integrate and educate the care team, both from the nursing standpoint, so that they can help monitor, symptoms, track efficacy, exacerbations, as well as adherence. And it also gives the member the opportunity to engage with their care team to ask questions and help with, side effect management, which leads to, fewer hospitalizations, fewer emergency room visits. And then we know that, rheumatoid arthritis and many of specialty conditions can be, progressive, and someone may start out on one therapy and maybe oral today. As, their time and their disease progresses, they may end up on an infused therapy. So rounding this out at what I would call the 7 o'clock position is the ability for members to receive home health care through lower cost site through quorum, in the event that the member should need to change to an infusion, to a higher cost, hospital infusion clinic to, say, receive a medication like Remicade. So I wanted to call this particular slide out to show you all of the many touch points and the way that in which, specialty members are supported, really to drive that specialty utilization and make sure that it's appropriate, and in doing so in a way that leads to, better outcomes and lower costs for our plan sponsors. The next slide really wanted to provide as a highlight, again, as I know many of you are having conversations with our mutual clients around specialty costs. It's really important to help them as they're evaluating various options, whether it's carve out of carve out of copay card strategies, that they really understand the value in which they have today. This will be a slide that you'll start to see in some of the annual review and insights meetings coming up, that really will give perspective of where the client's specific data, where they are as far as programs that they have in place, the savings and the value that those programs are offering them to date, but then also identify future opportunities and how they can continue to help mitigate their overall specialty spend and trend. And with that, I believe my next slide is really just a summary slide. And so I know with time, I want to be sensitive, see if there's any remaining questions from the audience today, but really thank you for the opportunity to kind of walk through the specialty management components.
Yeah, thank you, Tierra. There were some questions on the chat about programs to manage financial impact in some of these gene and cell-based therapies for low-wage workers, et cetera. It appears to me that Brian kind of defined CVS's standard approach of how those questions are answered. I guess this is a kind of a general question. Do you see a reference-based pricing model for specialty meds as being a possibility down the road?
I would say it's definitely something that, reference-based pricing is being explored. Would have to follow up with more details on that, but, value-based contracting, reference-based pricing, it's definitely an area that we are looking into and see it as a way of managing going forward for sure.
Yeah, I would agree. I would say that the value-based approach is more our goal, because we want to make sure that employers are not only getting the drug that they're paying for, but they're getting the outcome for that drug that they're paying for too, which is the most important thing. Is it working?
Excellent. Well, Tierra and Brian, thank you. I will turn this back over to Kevin Gregory of Health Action Council, and open the floor for any and all discussion that if we have any additional questions from the audience.
Yeah, so please, as questions come in, Rick, I would appreciate that. I want to thank Tierra. I also want to thank Brian for jumping in. I think the idea of specialty and the topic of it is not going away, and I think it's going to continue. We've had a number of conversations about carving out with a lot of our members and looking at different solutions. And sometimes it's just really understanding, I always like to say, the basic blocking and tackling what your current PBM is doing and comparing to, is it actually going to be any different or better, when you're carving it out from a solution standpoint. And the fact that, CVS in particular and some other folks in the PBM industry are also looking at, getting into the medical records instead of attestation from the medical doctors. They're really getting the medical records, which is requiring proof that they're actually, needing that drug and what they're doing. So I think that's good and looking at that. But broadly, what I was very pleased about, as Tierra was going through, is kind of the discussion around quality and some of the things that they do, because that's really a foundation of who Health Action Council is. And a lot of the things that we do, one of the things that wasn't mentioned too much, which we are really big on over here, is health literacy. So we put out contents every year for our members. Is one of the things that we do. We put out, the other thing that we pride ourselves on at Health Action Council is educating our members. So we educate consumers, and so they hopefully make better healthcare decisions. And that has shown up in our trend with CVS, which has been negative or single digit for the last 19 years in our CVS program. And then on our medical program, it's been running at 2.1% since 2010. The idea is, for what we do at Health Action Council, is we educate members and who are plan sponsors so they have better conversations with their consultants and their legal advisors about making the best decisions and informed decisions that lead to better outcomes. We did a recent white paper, and we talk about, I know there's a heavy emphasis on specialty drugs right now because they're pretty much going right through the roof. But I would also tell you, if we look at what I like to call the big five, which is asthma, diabetes, back disorders, hypertension, mental health, and substance abuse, those five things alone were responsible for all trend in our medical plan last year. So we look at that and focus in on those ideas and look at demographics and data within that in our most recent white paper with Optum and CVS. And one of the things that Tierra, we talked about was being compliant with medication. Our inappropriate use of the emergency department as a result of asthma is actually better than the national average because of quality and education of things that we do at Health Action Council. And that really kind of ties into other white papers that we've done about medication matters. So big picture about who Health Action Council is, we do three things, really: education, again, designed to make things better consumers of quality services and create better outcomes for what we do. And that shows up in what we do in our health improvement activities. Leapfrog Group, which is the hospitalsafetygrades.org. From a health literacy standpoint, I would argue that somebody who has a PhD from two of the finest schools on the planet Earth. You name whatever one you feel. I don't want to offend anybody who went to Yale or Harvard or Oxford or University of Minnesota. But again, they understand the difference between an A and an F, much like the person who did not graduate high school probably understands the difference between an A and an F. But it doesn't mean that they shouldn't be on the same plane when it comes to making a decision about going in for elective surgery. Health Action Council also does Find the Right Care. It is a free website. We encourage everyone to use it. findtherightcare.org. It is a resource tool that, as part of our nonprofit mission, we push out there. Last couple things on the Step It Up challenge. Budgets have gone weak on wellness plans. So today we have over, I think, nearly 1,000 people participating in a walking challenge, and those steppers are going to average probably over 11,000 steps. Again, it's all about getting upstream and making better choices. And lastly, I will spend a little bit of time on healthy kids. We're on the tail end of a pandemic. We're all feeling a little bit better. We're excited about what's to come as we move into the next normal. The one thing that I want to raise awareness of, and I encourage everyone to look at your data, encourage everyone to talk to your employees who had children over the last few years, to make sure that they're up to date on their immunizations, because we've had an immunization problem, and coming out of the pandemic, we don't want to bring back measles, mumps, rubella, whooping cough, chicken pox. These are vaccinations that are behind, they're lagging, so we need your help. So we'd encourage every plan sponsor, every consultant who's on this phone to talk with all of your client plan sponsors about making sure that their children who are on their plan are up to date on their immunizations and they're back to getting them again. It's an important aspect of what we do. The next thing that we do is really group purchasing. Again, it's about the members, and we follow an open source model designed to save money, improve outcomes, and retain control over the benefit programs. That retaining control over the benefit programs, as the plan sponsor and the consultants, we're here as that extra wheel to look at everything that you're doing, to add support to everything that you do. Here's our endorsed vendors. We're very pleased. Tierra spoke today from CVS. We also work with United and Optum, LabCorp for flu shots, IMED and VSP for vision. If you're not taking advantage of these, or you're out in the marketplace looking for a new vendor, we would love for everyone to join us and look up and consider Health Action Council as a partner in that space. We'd love for everybody to keep the conversation going. Sign up for our monthly newsletter, learn about that. Email us, info@healthactioncouncil.org. We'd love to hear from you. We're happy to have a conversation with everybody. You can go to our website. And there's always social media that everyone knows about: LinkedIn, Twitter, Facebook, and YouTube. We have our own YouTube channel. You can see some content that's out there. I appreciate everyone's time today. I really, really appreciate Tierra and Brian from CVS for helping us out. I'll stop talking, Rick, and see if there's any questions that are left that remain in the chat box to be addressed.
Yeah. Do you anticipate the pending transparency rules to have a positive impact on the net price of drugs?
Yeah, so this is Kevin. Yeah, in my opinion, yes. I think that there's a lot to those transparency. I think that some of the newer drugs are going to be coming out. I think some, from a competitive standpoint, are going to be there. There'll be some impact on it, but it won't be as much of an impact on prescription drugs per se, on the net cost of that, because a lot of what governs drug pricing is the Robinson-Patman Act, especially for brand drugs that's come out, which has class of trade rules on how they're priced and how well they can be discounted. So I think that's a pretty big area to have an impact on that, or have more of an impact on the medical than it will on the pharmacy. But I think some pharmacy impact will be there on transparency, as people are needing to disclose dollars, that revenue that's being earned, whether it's medical providers who are taking in rebate dollars or additional dollars coming out. So it'll have a little bit of an impact, but not as much as it will on medical plans.
One last question, Kevin. So how frequent are we learning of procurement issues with international purchase? And furthermore, how can we get the United States distribution to be better priced than international fulfillment?
That's an interesting question. I think international fulfillment, it's really even kind of a, Health Action Council is not in the lobbying business, so it's not really our space. I would tell you, people who are interested in lobbying could do that, but most of the other countries have price controls, which basically you're arbitraging the fact that, especially for brand drugs, you can get better pricing. Generic drugs in the United States, for the most part, are significantly cheaper than they are in other countries. So, when you go to a foreign country and you're accessing, medications, what you're really doing is, arbitraging the fact that the government there is essentially fixing the amount of money that they're going to be paying out to the manufacturer for that. As far as getting them reimported, I think there's been a lot of discussion about that over the last few years. Lobbyists, in the pharmacy industry and the Food and Drug Administration, who kind of manage that importation and bringing that in along with the USPS, it's a bigger issue than you think. There is some quality issues. We've seen some stories in it. There's some positive stories. It's not to say that every drug that's being dispensed, or coming in overseas is bad, but there's enough negative stories about people being shipped saline solution, or they're getting medications that have not been vetted and approved through the FDA here in the United States. That does bear some risk that I think plan sponsors and their advisors who are making that should contemplate as they're thinking about those issues.
All right, Kevin, we're coming up on 1:57, so I think that we've covered all the questions today. I'll let you wrap it up.
I appreciate everyone's time. We'd love to, if anybody else has any additionals about Health Action Council, we'd love to hear from you. And we'll be reaching out to you with the slides in the near future. Thanks, everybody.
Thank you.